All right, I think we'll go ahead and start. I know that many of us are probably absconding from work as we speak because it's in the early morning of the day. So we won't take too much of your time for today's session. We'll go ahead and start and record for the benefit of those of us who possibly could not abscond abscond from work. But most welcome to the second CME of the Bold Heart CME series. I believe we have three more remaining, possibly one this week and a second one. Yes, we do have one this week. The next one should be in the other week. The next one after that, the other week. And then the last one should be in February. So, as is our tradition, we'll start with a brief introduction for the benefit of those of us who have never seen quality care before. Possibly it's the first time interacting with quality care. So my name is Edgar. I am administrator here at Quality Care. My role at Quality Care is to make sure that trainings and CMEs alike all happen in an effective and efficient manner. So at Quality Care, we have a number of instructors. We have American Heart Association instructors. We have ICU instructors. We have POCUS instructors. Today, we are joined by one such instructor, an ICU instructor called Edna. She'll introduce herself. This is what she looks like when she comes on to take us through today's CME. So this is where we are located. This is along Gong Road, just before KNH. I know nursing officers who attended the previous CME have received their certificates. I know two nurses who uploaded their certificates and have gotten their CPDs. In case you haven't uploaded yours, or in case you haven't gotten in touch for the previous CME and gotten your certificate and you met all the necessary requirements as well as the CME, please do get in touch so that you can get your certificate and claim your CPD points as soon as possible. Medical officers, most likely we will be able to start issuing CPD points next week. The process of renewing our license seems to have taken a shorter time this time. In case that's the case, I will share an email where prompting you to get in touch and sharing all the necessary details so that you can claim your CPDs. Clinical officers, this is where we are based. Please bring your logbooks for stamping so that you can get your CPD points. The sooner, the better. Life is Why campaign is still on. Tomorrow we'll be in Makweni Hospital as part of the Life is Why campaign. Life is Why campaign is where we try and sensitize medics on the importance of high quality CPR when it comes to a patient in cardiac arrest. Today's focus is vent settings. But of course, if you do get a critical patient, very likely they will go into cardiac arrest. So advanced life support, very important in the critical care setup. And of course, basic life support, forming the foundation for any resuscitation attempt. Without high quality CPR, your patient who goes into cardiac arrest will not survive. Yes, so very, very important after attending today's CME. We hope you will share this knowledge, tell people about the importance of high quality CPR. If you work in ICU or critical care units and you have a vent there, and people don't know how to use it, we hope that you will share the knowledge that you get today. BLS, ACLS trainings, ICU course. We actually have an ICU course next week. Pre-hospital trauma life support, pediatric advanced life support, clinical ECG are just a number of the courses that we offer. If you're recertifying this month, you're supposed to get a discount. We welcome you to claim that discount. So today's CME will focus on the mechanical vent. There it is in the background. We'll be jumping into it in just a few minutes. Here is the podcast training happening, lung ultrasound happening as part of podcast, high quality CPR happening somewhere in the bush. Everyone should learn how to do it. Reason for this is because most cardiac arrests happen at home. So as quality care, we believe very strongly in everyone knowing how to do it. BLS training on the left for non-medical staff, ACLS training on the right for medical staff at our offices, PHTLS training for the medic who would want to work in the pre-hospital setup. You want to become a flight doctor, you want to become a flight nurse, you must have done pre-hospital trauma life support. Medics, you have so many options. You do not necessarily have to work in the in-hospital setup where you're constantly looking for locums, uh, looking for the next job. Expand your horizons, expand your portfolio. There's so many options out there. We have a number of partnerships. We do sell all these medical equipment. Now, to focusing on ICU. We'll be having an ICU course next week. Focus will, of course, be mechanical ventilator use. We'll be going deep into its use, the modes, the settings, the goals of ventilation when using the mechanical vent. We'll also be going into the management of your critical patient, how to manage shock, how to manage acid-based disorders, specifically acidosis, fluid resus, DKA, hypoxia, ARES, VALI, which is ventilator-associated lung injury, sodium, managing sodium levels in your critical patient, something that is often overlooked, but very, very important. We'll also be doing intubation and extubation. This course is specifically designed for medical officers, nursing officers. If you've done your critical care diploma and you feel this knowledge is not enough, in that case is when you come and do the ICU course. Clinical officers can also do the ICU short course. Medical officers, highly, highly recommended that you do it. We have a BLS ACLS training starting on Friday. I may be a bit late to join this one. However, we do have another one starting the final week of this month. If you are recertifying, unapata discount this month, please get in touch as soon as possible. We have podcast training first week of Feb. We welcome you for all of these other courses as well. This is where we are based. Clinical officers, please bring your logbooks as soon as possible in order to be stamped so that you can claim your CPD points. Medical officers, you get 10 CPD points. Nursing officers, you get 5. Medical officers, you also get 10. Tunawakaribisha sana. We thank you so much for taking the time to join us today. We know it's in the middle of the workday, may not be the most ideal time, but you have taken the time. This is where we are on social media, our website, our email address, and our Facebook page. We request you please follow us on Facebook. We are Quality Care Kenya there. Instagram, we also Quality Care Kenya there. Recently, we were at Kenyatta University. We're training very young medicine students. So they're saying Facebook is for old people. Can't believe it, but that's what the people are saying these days. Yes, so Instagram, TikTok, we're also on LinkedIn as Quality Care Kenya. We request that you please like us there. We also post a lot on medical updates as well as yes, just our trainings. So thank you so much for joining us today. I'll now invite Edna, our ICU instructor for today, to take us through mechanical ventilator settings. If you have any questions, please ask in the chat box. The chat box is live and we will respond. Thank you so much, everyone. Most welcome, Edna.
Okay, good morning, everyone, and welcome to this training. My name is Edna, part of Quality Care trainers. I'm an instructor with Quality Care for American Heart Association trainings and also ICU and point of care ultrasound. So today I'll be doing a brief CME on vent settings, the basic vent settings. Okay, so to begin with, let's talk about the vent settings. Before we go to our ventilator, I want to talk about the vent settings. Just a minute. Okay, so in the vent settings, once you interact with a ventilator, you need to now set have to set the ventilator so it's ready to ventilate the patient. And this comes in when we have maybe intubated the patient or the patient is on non-invasive ventilation. These are patients who you want to support the ventilation. So a ventilator is a machine that supports ventilation by delivering air or oxygen via positive pressure. Now, the modern ventilator do by positive pressure. Traditionally, that is back in the 1800s, maybe, or 1900s, there was the negative pressure ventilation, but currently we are using the positive pressure ventilation. So with that, now once you've decided to put your patient on a mechanical ventilator, the next thing is you're going to be choosing the mode. And we'll talk briefly about the modes that you can choose of mechanical ventilator. And once you've chosen the mode, the next thing you need to decide is the settings that you're going to put your patient on. So I'll talk about the settings that are there in a ventilator. To divide the settings, I divide the settings on one, we have the universal settings. And for the universal settings, this means that any patient that is ventilated, any patient on a mechanical ventilator, whether the patient has a endotracheal tube, a tracheostomy, or they are not even, they do not have an advanced airway. That is, you want to ventilate them through an invasive ventilator using maybe a mask. These are settings that will cut across all the patients. So the universal settings are two settings, and we have one, the FiO2. In full, fraction of inspired oxygen is the percentage of oxygen that you're going to give to your patient. For example, as in room air, we have a fraction of inspired oxygen from the air, from the general air that we are breathing in. And our FiO2 in room air is 21%. That is the normal one that we are getting above sea level. If you give your patient supplemental oxygen, that means there's a percentage that you're giving your patients in addition to the room air. Now, when you put your patient on a ventilator, you have to think about the fraction of inspired oxygen that you want to give. Most of the time, if it's invasive ventilator, this is a patient who has hypoxemia or is hypoxic. These are patients with respiratory failure. You want to start maybe with 100% and you will titrate. Now that's in advanced ICU. Now we are thinking about what are the goals of oxygenation. But for every patient on a mechanical ventilator, they have to have an FiO2. That is the first universal setting. The second universal setting is something we call the PEEP. P-E-E-P. And PEEP is in full positive and expiratory pressure. Now, this is a universal setting. Whether the patient is intubated, they have an advanced airway, or they do not have an advanced airway, whether it will be invasive or non-invasive, you have to set the PEEP. Now, PEEP, which is the positive and expiratory pressure, this means when the patient is expiring or when they are breathing out, there's a pressure that remains in the alveoli at the end of the expiration. The work of this pressure is to ensure the alveoli does not collapse. So there's no collapse of the alveoli. Now, even a normal breathing person, like us, if we are not intubated, we are not in a mechanical ventilator, we have our own PEEP. And physiologically, the PEEP is usually 5 centimeters of water. For some patients, especially those with oxygenation issue, like a patient with ARDS, you can go higher on the PEEP. So that's the second universal setting that we have. So universal setting is the first thing that you have to think about. We have two, that is the FiO2, fraction of inspired oxygen, and we have the PEEP, positive and expiratory pressure. From the universal setting, we have the next thing, which is major settings. Now, these are the settings that you have to think they are major. and they depend on the mode of ventilation that you've chosen. For the major settings, now you want to think what you want to cycle. Cycle is what you want at the end of that inspiration. What do you want delivered? Is it volume or is it pressure? So for the major settings, if you decide it's volume, what you're going to set is the tidal volume. If you decide to cycle pressure, what you're going to set is the pressure control. The other thing on major settings is the respiratory rate. So for this one, it's either volume or pressure. You have to think about the respiratory rate. And the last thing on the major settings, which happens in some modes, is the pressure support. Now, this happens in case the patient is waking up and maybe they are breathing on their own. For some vents modes, you need, when the patient initiates their own breath, you want to give some support to the initiated breath by the patient. So for the major settings, we either have tidal volume or pressure control, respiratory rates, or the pressure support. That is in the major settings. Then the last thing now is other settings. So for other settings is anything else that you want to set, additional things that you want to set in the ventilator. The first thing that you can think about is trigger. And trigger is what initiates a breath. What is initiating a breath? How do you want it to be initiated? And for trigger, we can either, the breath can either be triggered by the machine. Now, assume this patient is not breathing. Maybe they do not have any respiratory effort at all. So the machine itself can trigger a breath. So that is the ventilator trigger. And this one mostly is by the respiratory rate. So if you set a respiratory rate of 12, so after every 5 seconds, the machine will be triggered to give a breath. We also have a patient trigger, and the patient trigger now is either by pressure trigger, where the pressure, let's say the diaphragm drops, now that reduces the pressure in the airway, and the machine will be triggered now to give a breath. So that's something that we are going to set, a trigger, either from the machine or from the patient. The other thing we set is the flow pattern. And which pattern do you want? Is it square? Is it descending pattern? How you want that breath to be given? And the last thing that we set in our machine is we can also set the flow rate. Especially when we are giving the volume, we want to set the flow rate. That is at what rate do I want this air to be given, whether it's by 60 liters per minute, 40 liters per minute, 90 liters per minute, just the same way as you give your oxygen via non-invasive way. That's the same concept. The other thing is the IE ratio. And for the IE ratio is in full is the inspiration to expiration time. So that ratio. For example, you've set a respiratory rate of 10, let's assume 10. So if it's 10 breaths per minute, That means between each breath, we have 6 seconds. So if I set the IE ratio, what I'm trying to decide is, in these 6 seconds that I have for one breath, how many seconds do I want these patients to use to inspire, and how many seconds do I want these patients to use to expire? So, for example, if you have a patient with oxygenation issue, for example, an ARDS patient with acute respiratory distress syndrome, these are patients who need a lot of oxygen, so they have an issue with oxygenation. So I want this patient to take more time to inspire. So if it's 6 seconds, I can choose them to use 4 seconds to inspire and 2 seconds to expire. Now, another case is for a patient with asthma or a patient with COPD. This is a patient who has a reactive airway. They want these patients, they are at a risk of having breath being stuck, something we call autopy. So this is a patient when I am doing this vent setting, I want them, if it's the 6 seconds that I have, I want them to use less time to inspire and more time to expire. So for example, I can have them use 2 seconds to inspire and 4 seconds to expire because they require more time to expire than to inspire. And that is the IE ratio. So those are the vent settings that we have. We have the universal, that is the FiO2 and the PEEP. Then we have other major settings where we have either volume control, pressure control. We have respiratory rate and pressure support for some modes. And other settings, the trigger, the flow pattern, the flow rates, and the IE ratio. Quickly, I'm discussing on some basic vent settings. And for the basic vent settings, we have one called assist control. And assist control is when I want to control, to give, control everything for this patient. Assuming this patient has no effort at all to breathe. You can put this patient on assist control. What it means is what I have said the patient will get, whether they have an effort to breathe or they do not have an effort to breathe. So for this one, we first set the universal setting. So I'm going to set the FiO2 or the and the PEEP, sorry. The other thing is I'll decide whether to cycle pressure or to cycle volume, and this depends on your patient. What do I want to cycle? What's the condition of the patient? Let's say the patient did not have any chest issues, so you can decide to go with the volume. For patients who you think they are having ARDS, you want to either go low on volume or you can use the pressure control. So for this one, you can set the tidal volume, which tidal volume is 6 to 8 mils per ideal body weight. Yes, Eve, just a minute. Then we have the other setting that you can set is the respiratory rate. Then we can set for this assist control, since it's assisting, it gives mandatory breaths. It gives whether the patient is breathing on their own or they can initiate their breath or not. You're giving that. We do not set the pressure support. For other settings, now we can do the trigger. We can also do the IE ratio. We can do the flow rates and the flow pattern. that is with assist control. Now, Eve is asking in the chat box, what if the vent does not have leeway to change some of these other settings? What can be changed to affect that? So most ventilators, they have the basic settings. That is, we have the universal, that is a must. Whether it's the transport ventilator, the small ventilator, or any ventilator, they must have the universal settings and the major settings. The other thing that is there is to ensure that you have the major settings. Universal settings are there, and the major settings, they should be there. That is, you can be able to set the respiratory rates. That is, if you're giving full support to the patients. The other thing is pressure or volume cycle. And the other thing is to either pressure support for that patient, which the mode allows. So for that, you have to ensure that your ventilator, depending on your patient, if your ventilator does not allow to get the other settings, the safe one is to use mode that is known as synchronized intermittent mechanical ventilator, where the patient can be able to initiate their own breath. Now, for that case, if your ventilator is like that, I would advise for the patient who do not have any respiratory efforts, avoid putting them in such a ventilator where you cannot monitor other settings. For example, the IE ratio, the trigger, yes. So that is for assist control. For assist control, we want the universal settings, the major settings, other settings. Thank you, Eve. The other common mechanical ventilator mode is SIMV. This is quite common. The full name is synchronized intermittent mandatory ventilator. So for the SIMV, what happens is, this is a mode that gives mandatory breaths for the patients, and at the same time, it allows the patients to have spontaneous breaths. So what you are going to set first is the universal settings. So we have the FiO2, we have the PEEP, that is mandatory to set for all patients on a mechanical ventilator. The other thing that we are going to set in this one is now the major settings, where we are either going to cycle tidal volume or the pressure control. And in this one, now we are going to set the pressure support. What pressure support is in case these patients decide to initiate their own breath. The ventilator will not give the mandatory breath, but it will allow the patients to have spontaneous breath. And because the patient might not be able to have an adequate breath, they are going to give some pressure support. So you're going to set some pressure support in addition for the spontaneous breath by the patient. Then the other thing that you're going to set now is the other settings, which is now we have the IE ratio, depending on your patient, your flow rates or pattern, your trigger, all that. That is the synchronized intermittent mandatory ventilation. Now, this one is when you're trying to wean off the patient from mechanical ventilator. So you mean you just intubated your patient, the patient is now waking up, you're thinking about, I need this patient out of the ventilator. Now you can remove them from the full support which was the assist control, because this is full support, and allowed the patients to do some work on themselves, so we can go to the SIMV mode. The last common mechanical ventilator mode is the pressure support, or it can be known as the spontaneous ventilation. So for this one, it can either be for a patient who is intubated, that is, they have an advanced airway, or a patient who is intubated or has a tracheostomy, and you're trying to wean off mechanical ventilator. What spontaneous ventilation or the pressure support, some ventilator call it CPAP mode, means is the patient is doing all the work. What the ventilator is doing is supporting whatever the patient initiates. So there is no mandatory breath that is being given from the machine. So what to set in this mode? One is the universal settings, as always. That is the FiO2 and the PEEP. Then the other thing that we are going to set in this one is now the pressure support. And that's all. So whatever volume is made, whatever pressure is used, that is dependent on the patient. Whatever they decide, the respiratory rate is dependent on the patient. Remember, the breaths, they are being initiated by the patients. And those are the basic or the most common ventilator modes that we set. And those are the common settings. Now we have other advanced modes, like the pressure regulated volume control. We have the airway pressure release ventilation, and then we have the high frequency oscillation. Those are advanced modes, not commonly used, but they are quite good, especially for the ARDS patients, which we are not going to discuss here. So with that, let's go to the mechanical ventilator and see where to start once we've decided to put our patient on a mechanical ventilator. Any questions before we proceed to the mechanical ventilator? You can put it on the chat box. You ready? Ready. Okay. So there's a question on the chat box on, okay, we're starting the sound right now. Okay. So this is our ventilator. I started on the back side because I want to show you what is on the back. Now this blue or green stuff is to connect to oxygen. So this pipe, we're going to connect it on the oxygen, which is on the wall. This one. Then we have a power cable. Each ventilator comes with a power cable. However, most of them have a battery that once there is no electricity, can survive for some time. Then we have the power on button back here. For most ventilators, the power on button is usually right here. And I have switched on the ventilator. So once you switch on the ventilator, take some time to switch on. The first thing once you switch on the ventilator is you want to do a system self-check. This is to ensure that your ventilator is in a good condition. And for the system self-check, you want to check the oxygen, if it's okay. You want to check the pipes, ensure the pipes are okay. Then you want to ensure there's no leakage. The pressure in the pipes is all okay. The next thing, so hope it's seen. So once I've switched on, of course, I can see the test. And then we can skip. I'll advise before you use the ventilator, just ensure that you test it. The test is for the leak test. We have the flow sensor test, the pressure sensor test, safety valve, and once it has passed, now you can confirm and proceed. I'll skip because I am not connected to the oxygen, so the ventilator is going to fail. So I can skip that. Now I have skipped. Now I move to the settings. Now this assumes that we're assuming that we've passed the test. So for the settings, we have, it will ask you whether it's a new patient or it was the patient that was existing, whether it's the previous patients. Now I'll choose the new patient. Then the next thing, it wants to know whether it's male or female. I'll choose female. Is it an adult or is it a child? We choose an adult. And then the next thing is we choose the centimeters or the height of the patient. So let's assume the patient is 160 centimeters. And now we are given the ideal body weight, which we are supposed to be using as 53. I need to confirm that. The other thing that you want to confirm is whether it's invasive or non-invasive ventilation. So for the invasive ventilation is for that patient who is intubated or for that patient on a tracheostomy. For the non-invasive, let's assume it's a CCF patient with congestive cardiac failure or a patient with pulmonary edema, which you want to avoid intubating, so you can choose non-invasive. So I'll choose invasive first and then enter. Now, once you enter, you have the first thing is the modes. The modes of ventilation. The first mode that we've talked about is the VCV, PCV. Let me first talk about these. These are the AC modes. So for the AC modes, we have the volume control ventilation, that is assist control, or the pressure control ventilation. So I'll choose volume control ventilation, assist control volume cycle. That is what it means. And now here I have the settings. The first setting that we talked about is the FiO2, and that is the universal settings, the percentage of oxygen. Now, to begin with, once I have intubated my patient and just want to start ventilating the patient, you want to start at 100% FiO2. So I'll move to 100% and accept. Now, PEEP, positive end expiratory pressure. The pressure at the end of expiration. You want it to be physiologic. There's someone on the chat box who has asked when we do it at 0. Now, even a normal ventilating patient who is not on a ventilator, just room air, like me, the physiologic one is usually 5 centimeters of water. So ideally, we should not go below 5. What it means if I set the PEEP at zero, sorry. What it means if we set the PEEP at 0, it's that once the patient is expiring, there will be collapse of the alveoli. You do not want to cause collapse. This causes atelectasis. So the physiologic one is 4 to 5. So at any time you want to set at 5. Now, for some patients, let's assume a patient is COPD patient. These are patients who can have a lot of breath stacking. Maybe you can set at 4. But I've not seen a literature that talks about anything less than 4. So let's keep it at the physiologic level. Then since we are cycling volume, we want to set the tidal volume. And the tidal volume for a normal lung is 6 to 8 mils per kg. So for our ideal body weight was 53. So I can choose 6 or 8. See, if the chest is okay, you can choose 8. So 8 mils times 53. 8 times 53. So I'm waiting for the calculator.
424.
So 424. So I'm going to set the tidal volume at 420 or 430, since it doesn't come with other numbers. So now we are at the major settings. I've started with the tidal volume, which is a major setting. The other thing is the respiratory rate. At what rate do I want these breaths to be given? So we can set anything between 12 and 20. And this depends on your patient. Remember, you've done a BGA before you put your patient on a mechanical ventilator. So if your patient has ventilation issue, that is, let's assume you have high PaCO2, you want to remove it. If the patient has, let's say, respiratory acidosis, maybe you can go as high as 20, but you can go even as high as 30, but not more than 32. So let's say 20. Now, the other thing that we are setting is, once we've set 20, that means between breath and breath is 3 seconds. Most of the time, it's going to give you the IE ratio. That is the time to inspire and the time to expire. For your patient, depending on your patient, if your patient is a COPD patient, maybe you want to reduce on the RR. And or if your patient is an ARDS patient, you want to do at 20, and then ensure that you set the time to inspire. Maybe you can go to 2. That is the inverse, and 1 second to expire. If it's a COPD patient, let's assume you're doing at 12. You can use 1 second to inspire and 1 second to inspire and 4 seconds to expire. And that's how we do the IE ratio. Now, other things that we set in other settings is the trigger. When do I want the breath to be initiated? Now we have ventilator trigger. If the patient is, let's say they do not have any respiratory effort, whatever I set as the respiratory rate, after the seconds, the machine is definitely going to give a breath. For a patient on a patient trigger, we can either set the pressure trigger or we can set the volume trigger. So because I'm cycling volume, so it will be low, it will be on the flow trigger. And this is how do you want it to be reduced on the airway for breath to be initiated. So we either set -2 or 3. So we can set at 2. And once we are done with that, now we can start ventilating. Now, the other thing he didn't mention is we need to have the tubes. And this is where we put the tubes. We have the one to expire, the one to inspire, and we connect it to a patient. And our patient is now breathing. Our patient now is being ventilated. And down here we have, on this side, we have curves. So we have the flow curve and we have the volume. What volume is getting in and how it's getting out, and the flow of the air that is being given. Now, the other setting that I need to talk about is the alarms. And alarms, or the limit, is what limit do I want to set on this patient, so that in case it goes higher or it goes lower, the ventilator alarms and alerts me I need to check on the patient. So things that we set is something like the pressure. What is the lowest pressure? That is the peak inspiratory pressure, the pressure on the airways. What should be the lowest and what should be the highest? Then we need to talk about the tidal volume, the lowest, then the saturations, the PEEP, what should be the highest PEEP in case the patient is retaining a lot of breath, the PEEP goes high. And here we can set on the alarm volume. So in case there's any issue, the alarm is going to be quite high, and that's to alert you that you need to check on your patient. Okay. So that's one of the ventilator settings. That is the AC, that is assist control. The other ventilator setting that we can talk about is the SIMV. So SIMV, which is the synchronized intermittent mandatory ventilation. And for this one, the settings that we put, the first thing we can either choose to give the first settings first. First things first, we have to have the FiO2. If I'm just starting to ventilate the patient, we can start at 100. Then we have the PEEP, positive end expiratory pressure. Then we have the tidal volume, where we are giving it at we are giving it at 6 to 8 mils for a normal lung. If the lung has ARDS, now we go at 6 mils, 4 to 6 mils per kg. We want to go low on the volume so as to avoid barotrauma. And then we have the respiratory rate. Now, in this mode, what happens is we want to allow the patients to breathe on themselves. For that, I'm not going to give a very high respiratory rate. Maybe I can give 10 or 12. And the patient is going to 12. Let's assume now the respiratory rate is 20. That means 8 is from the patient. The 8 that comes from the patient, I want it to be supported. Give a little support. So I'm going to do the pressure support. And that is add some pressure support. Maybe I can give 10 or 12. And this means in case the patient decides to breathe on themselves, when they initiate the breath, I'm going to give 15, 12 centimeters. Other things is the time to inspire. And then after that, I can accept. And start. So I've just started ventilating on SIMV plus the pressure support. So in case the patient decides to breathe on themselves, they are supported by the ventilator with some pressure support. Now, the other basic mode is the spontaneous breath. And that one can either be for invasive patient who is intubated or there is a tracheostomy, or the non-invasive. So you can go to the non-invasive patient. Okay. So this is a patient who you've put on a mask. Okay. So for the non-invasive, we can do the CPAP. And for the CPAP, what we are setting is one, we are going to give the FiO2. Let's say we give in at 60 or 70. This is someone we just want to support with some oxygen as usual. And then the PEEP. That is, we can even give at 5 of the pressure support that we are giving, because this is a patient who is not intubated. And once we accept, we start. So this is a patient who is breathing on themselves. There's not much that the ventilator is doing apart from the pressure support. And that's the basics of ventilators. Okay, thank you, Eve. You say you've used the same ventilator. Yes, you can set the IE ratio, and this one mostly it depends with the patient. So it's patient dependent what you want to set on your patient, depending on your patient, if it's a oxygenation issue or if it's a ventilation issue. Now, once you've put your patient on a mechanical ventilator, after you put in the settings and you've given the mode and all that, the patient is on a ventilator, you've set the limits. That is another thing that you need to set so that so that your ventilator alarms in case there's an issue. Now, there are other things to look for these ventilated patients. The first thing is the goals of oxygenation. So you need to have the goals that you need to check each and every day. So the goals of oxygenation is one, the acceptable saturations. You need to have saturations above 88%. Do not aim at 100%. Then your patient should be hemodynamically stable. So because if it's oxygenation, most of the time you're looking at the FiO2 or the PEEP. You don't want to give a lot of PEEP because it reduces the cardiac, increases the intrathoracic pressure, reducing the venous returns, reducing the cardiac output. So your patient needs to be hemodynamically stable, and you need to ensure that your patient is saturating well. Then there are other goals of ventilation. The goals of ventilation is there's no auto-PEEP, and the auto-PEEP is when there's breath stacking. There should be acceptable pH and PCO2. That is, the patient is able to breathe in and breathe out well, and there's washout of the CO2. There's no accumulation of the CO2. And the last thing is the plateau pressure. Now, plateau pressure is the pressure of the end inspiration in the pressure in the alveoli once the patient is inspiring at the end of inspiration. So those are the things that you need to look out for. And I want to end the CME at this point. Any questions? Any questions? I'll leave the floor to Edgar if there are no questions. Thank you, Gloria. Eve, oh yeah, thank you. Plateau pressure. When do we choose PCV and BCV mode? Okay, so depends on your patients. Now, once we choose, this is wide, once we choose pressure cycle, this means I'm going to choose the pressure and the volume that is at the end of the inspiration is variance. Now, let's assume your patient, you do not want to give a lot of volume. For example, patient with compliance issues, patient with something like ARDS. So this patient, you want to regulate the volume that gets in. So you can give pressure. So for the patients that you want to monitor the minute ventilation, which is volume times respiratory rate, we can choose pressure. So depends with what you want to monitor. Is it pressure? Is it volume? Again, depends with the compliance of your patients, the compliance of the alveoli. If the compliance is compromised, for example, in ARDS, it's safer to cycle pressure. If your patient does not have any issue with the lungs, you're just intubating for other reasons, it's safe to go with volume. How do we go about setting flow trigger? Okay, so for flow trigger, most of the time, we do it when we are in volume cycle. And flow trigger works almost the same as pressure trigger. And this is the flow, we have like a bias flow of from the ventilator to the patient, inspiration and expiration. So let's say you've given a flow trigger of 2 liters. So what it's going to do is when it's time to give a breath, there will be drop in the flow in the airway. So once there's a drop in the flow, the ventilator is triggered to give a breath. Same case with pressure. Once there's a drop, for example, the diaphragm goes down, there's a drop in pressure in the airway, the ventilator is going to sense that and it will know it's time to give a breath. That's how we go about it. So thank you, Erastus. I want to end at this point. Thank you and see you.
All right. So thank you, Edna, very much for that very insightful session. For those who have just joined or joined towards the end of the session, my name is Edgar. Now, the ICU course is very comprehensive. That is just that is just the tip of the iceberg. So we highly, highly recommend if you do work with critical patients, just to give your patients the best. We recommend, highly, highly recommend doing the ICU course. The mechanical vent is just but a portion of managing your patient who goes, who your critical patient. So we have gone a bit extra time. Thank you very much, everyone, for joining us today. CPD points and MOs will likely start issuing next week. If our license is out next week, I will share an email where prompting you to get in touch to claim your CPDs. If you attended the previous one and met the requirements for being able to claim the CPDs, that is registering in good time, making payments in good time, and of course, attending the CME. The goal of the CMEs is to promote knowledge and understanding to the best of our ability. After attending the CME, and possibly you come across someone somewhere who's using a mechanical vent, and they don't know how to use it, please show them these settings. In that regard, we improve emergency care here in Kenya, which is the ultimate goal for these CMEs. Nursing officers, please get in touch via I'll send an email after this. Please get in touch with your details, names, name on Zoom, and payment confirmation. Then I'll share your certificate. Clinical officers, please come to Ngong Road in order to have your logbook stamped. Unfortunately, the online system inatusumbua hadi wa leo. Yes, please come physically in order to claim your CPDs. 10 CPDs for clinical officers, 10 CPDs for medical officers, and 5 CPDs for nursing officers. Nurses would have wanted to give you more, but the Nursing Council of Kenya says maximum for an online session like this is 5 points. All right. Thank you so much, guys, for making the time. We'll be having the next CME most likely after next week. I'll share the poster in the alumni group once more. Focus of that CME will be pediatric advanced life support, so the pediatric population. If you know a friend or a colleague who does deal with the peds population a lot, children's and infants, please encourage them to join. Having said that, have a great rest of your Wednesday. In case of any questions, comments, or concerns, we are still there. Please let us know, and we'll assist to the best of our ability. Asanteni sana. See you in the next CME. Thank you, Stephanie. Thank you, guys. Goodbye.